Thanks, Mr. Chairman, and thanks for the organizing committee for inviting me. And I think I have a difficult task to present the last after a long meeting. My knees are shaking, and I know why they are shaking. I'm presenting in front of Professor Zain Karar, and my knees used always to shake when I'm presenting in front of him in the ward rounds. The target audience, I was told, it was going to be junior doctors. So I've tried to keep my research, my presentation quite focused and simple. And the presentation I'm going to talk to is mainly about smoking and diabetes. And smoking and diabetes are among the leading causes of death in the developed countries. And the main causes of death from smoking are mainly cardiovascular disease. And the main causes of death from diabetes are actually cardiovascular disease. They share lots of things in common. One of them is the increased risk of morbidity and mortality. The other thing is the huge impact on the economies in terms of either directly by the increased risk on morbidity and mortality or indirectly through loss of productivity. And ironically, the WHO has estimated that there is about 6 deaths per minute related to smoking and similar number related to diabetes globally. And if you looked at the figure down at the bottom of the slide about the impact on the global economy, 375 billion was spent on managing diabetes, and that was in 2010. And 50% of this was actually spent on treating the complications of diabetes. 30% of this is actually an estimate on the loss of productivity. And only about 20% of all this money is actually spent on managing diabetes. So again, as Dr. Bremer has highlighted, diabetes is actually recognized as a global pandemic. And in 2010, the WHO estimated there's about 285 million persons with type 2 diabetes. And this estimate is actually changing every year. In 2003, they estimated by the year 2030, there will be 300 million. And then they came in 2010 and they found there's already 285 million persons with type 2 diabetes. I think they're struggling to predict, but the global incidence or prevalence of diabetes is about 6%. In Ireland, there's no data, but it's estimated to be about 5 to 6%. So how does the diabetes and smoking interact? They interact in 2 ways. Smoking increases the risk of type 2 diabetes, regardless of the race, regarding of the age, regarding of the gender, and regardless of the weight. And the risk, and the more you smoke, the higher your risk of developing diabetes. And then it increased the risk of cardiovascular disease. It added an extra 41% risk of cardiovascular disease in patients with type 2 diabetes. It kills. It increased the risk of mortality in patients with type 2 diabetes. If you smoke more, the risk is actually doubled. And the only thing that can help in normalizing the risk is to give up smoking, and you need to have 10 years off cigarettes before the risk normalizes. So our first look at the study, we were trying to look how does smoking affect the glycemic control and the blood pressure. So I was lucky I was working in a center where we had a database. So we looked at our database, we identified 400 patient smokers and matched them for age, gender, and BMI and duration of diabetes. And this table is basically showing that we actually did manage to get a match group. And this table is actually showing that smoking actually did worsen the glycemic control, worsens the lipids profile, but had no effect on the blood pressure. If there's any diabetologist in this session, will realize that the mean HbA1c that you have is actually within a very well-controlled category. The hospital I was working in is actually in Dublin 4, the most posh area in the country, high socioeconomics, very motivated group of patients. The difference we found was mainly quite minimal, still statistically significant and clinically significant. The no change in the blood pressure was not of a surprise. Smoking hasn't shown to have has any effect on hypertension if we're using the usual methods of of recording only the clinic readings. But if you use the results using 24 hours blood pressure monitor, the outcome might be a little bit different. We looked at the data in another way, looking at how many did not achieve the targets, not how many did achieve the targets, how many did not achieve the targets control according to the ADA guidelines. And again, all smokers, the majority of the smokers did not manage to achieve the target metabolic control. The second look, we were looking at the albumin-creatinine ratio, and mainly we look at the glomerular filtration rate. And this has been looked before, but there's been huge interest in glomerular filtration rate as a predictive of increased cardiovascular risk. And there's been increasingly described cases describing patients with diabetic nephropathy who did not have any form of albuminuria. Again, we looked at the same database, and we identified two groups. They were well matched, similar to the table I just presented. And again, smokers were more likely to develop micro and macroalbuminuria, and microalbuminuria is linked to increased risk of cardiovascular disease. Macroalbuminuria is the same, in addition to increased risk of end-stage renal disease. And then when we looked at the rate of decline in GFR over a period of 3 years, smokers' GFR declined by about 10 mils per minute, while non-smokers were basically, there has been no change. There is a slight increase, but not statistically significant. And to put things in context, we don't know what's the normal rate of decline in diabetics. Some studies suggest it's actually 1. Some studies suggest it's more than that. We don't know. But what we know is that the decline in the GFR is actually strongly linked to increased risk of cardiovascular disease and end-stage renal disease. So basically what we have shown that in type 2 diabetes, smoking is bad for you. Smoking worsens the glycemic control. It worsens your lipid control. There's a high risk of macroalbuminuria and macroalbuminuria, and there is a high rate of decline in the GFR. And as answering the questions that we were asked, and this is mainly targeting trainees, I think before conducting any research, you have to do your homework, and you have to basically study. You have to have basic understanding of what's research methodology, how to undertake a literature review, and how to be able to formulate a valid scientific question. Basic understanding of statistics, and if it's at all possible, I think involving a statistician early in the study would be of great help in the design, in the data collection, and to know exactly how many patients you need to use. And the presence of research tools, databases or research nurses, all this will help in conducting a good research. So the main challenges, and I was actually looking at it from an Irish prospect. So if you're a consultant now working in any of the Irish hospitals, there's a huge clinical commitment. The HSE is trying to move the consultants down to the A&E to do acute medicine, and the consultants have been handed again huge management commitments. So there is actually little time to be devoted for research. If you're a trainee, there is no protected time for research or audits. And all the research that the research I've presented, I've done that while I was working as a research fellow. There is a staff shortage all over, and there is increased workload. And not in every hospital you will find a supportive research tools, in particularly databases or research nurses. And does it matter at all? I think, and how did it help research in my career? It did help. I managed to get an academic degree, but I think, does research make you a better clinician or not? It depends on, really depends on the research, but in general, I think it does. In diabetes, there is 5-6 big journals that publish every single month. There is at least 150 papers coming through every single month. Research helps you to be able to be selective, to be able to do a good critical appraisals, to know exactly what type of articles you can actually implement in improving the service of your, the outcome of your patients. And it actually it will help in making you a better clinician. And again, with research, publications, and presentations, it makes the candidate more competitive for jobs. Thank you very much.